Assalamu alaikum everyone. Welcome to the Neurosurgical case room. Am I audible?
Yes, ma'am.
Yes.
Yes, ma'am.
Walaikum. Yes,
Uh,
audible.
everyone who is not muted, please mute yourself so that we can proceed without any disruptions. Let's begin. So, hopefully we are going to breeze through this session, inshallah ta'ala, because we have covered the Sylvian Fissure anatomy, then the temporal lobe, then the frontal, and then the insula as well, along with the some anatomy of MCA, so that understanding this is easier. There's nothing really difficult about Sylvian Fissure splitting if you know the anatomy. So let's hope we are going to have an easy way today. This is an illustration for the pterional craniotomy, which is the workhorse, the standard surgical corridor for the transsylvian root or for the Sylvian Fissure dissection. And we have discussed this previously in a few other sessions, so I'm not going in the detail. But just so you know, and there is this rough idea that we make the first burr along the keyhole. This is the keyhole here. And usually if you are making only single burr hole, then this is the only burr hole you're going to make, and then you're going to use a craniotome to draw this entire craniotomy and take the bone off. The important thing that I wanted to emphasize is we have previously discussed that even though we still need to rongeur this portion off. This is the lesser wing of the sphenoid, the one that I'm marking in the green right now. In fact, let me change the color. So this portion here still needs to be rongeured off. If you do not rongeur it, the gap between the frontal lobe and the temporal lobe is not going to be a lot. You will not find the natural corridor and the natural space that the Sylvian Fissure offers. To reach that, you will need to rongeur this off in a way that the floor of the anterior cranial fossa and the floor of the middle cranial fossa, which is right here, and they are flush. So instead of it going like this in a form of ridge, it should go very smoothly like this. This entire thing needs to go away. Oftentimes, we need to take the anterior clinoidal process as well, depending on the lesion for which we are using the transsylvian route, but that's optional and that's also lesion dependent. Lesser wing rongering is not lesion dependent. You will need to rongere it if you want an easy time around the Sylvian Fissure dissection. So, moving on. Also, I included this figure because even though we have discussed the venous drainage briefly, there were a few important things that I wanted to mention. Let me change the color so that it's visible. So what you see here is the superficial middle cerebral vein, which is also known as the superficial Sylvian vein. Now, this vein is like a main corridor. It's like a main transit, and it has multiple exit routes. You can see the first variation, which is the superior drainage, where this is connecting to, which vein is this? The superior anastomotic vein. What is it called?
Trollard.
That's right. So this is vein of Trollard, right? And this is the superior pathway. So one variation is that the superficial middle cerebral vein is only going to drain superiorly, not anywhere else. Rest of the veins or the sinuses are hypoplastic. The other variation is, let's do the posterior drainage first. The superior anastomotic vein is, we are assuming that it is hypoplastic. The other alternate drainage would be, what's this inferior anastomotic vein called? That's right, this is vein of Labbé. Please mute yourself. Somebody has a lot of background noise. So this is inferior anastomotic vein. This is the vein of Labbé as well. It connects to the transverse sinus posteriorly. So this is the posterior drainage. Then we have the anterior drainage. The vein goes anteriorly. Can someone mention what sinus is here anteriorly? Anyone? We have
Spinos-
a sphenoparietal sinus here. And sphenoparietal sinus is right at the lesser wing of the sphenoid. So I'm going to draw a very rough illustration. This is the lesser wing. We have the anterior clinodal process, the other anterior clinodal process, and then this is the opposite side, lesser wing of a sphenoid. So the sphenoparietal sinus runs around here, and then it connects to the cavernous sinus, to the inferior petrosal sinus, etc., etc. So all this discussion means that we need to know where the vein is draining, because this vein is non-negotiable. You cannot sacrifice it. If you end up sacrificing, patient is going to have a huge infarct post-operatively. And it's also important to know the variation it might have. It might have only the superior drainage. It might have only the anterior drainage where it is draining into the sphenoparietal sinus and towards the cavernous sinus, etc., or the posterior drainage in which it is draining in the vein of Labbé. Or sometimes, which is often the case, it could have mixed drainage, draining some portion in each of the veins. So this is the main highway and it has multiple exits. Are we all clear about this? Am I audible?
Yes.
Yes, ma'am.
Okay. So let's move. Since we are not going to discuss the craniotomy, we are assuming that we have already done the craniotomy and the extradural dissection has been done. We have opened the dura and the dural flap has been retracted downwards. We have ample space to work around. But the brain is tight. For example, if we are operating on a patient with subarachnoid hemorrhage or ICA, intracerebral hemorrhage, let's say. So if for any reason the brain is tight, it's a very bad idea on the operating table to dissect the Sylvian fissure manually and, try separating the opercula, excuse me, trying to separate the opercula while they are firmly opposed together. So what are we going to do? We are going to do the our standard procedures that we use to reduce the ICP and to reduce the brain edema. That might include mannitol, that might include hyperventilation, that might include head elevation, making sure that there is no kinking around the jugular vein, etc. And, just optimizing all the other maneuvers so that we are 100% sure that the brain is relaxed. In the cases where this does not end up achieving the desired result, the other option is a lumbar puncture or lumbar drain, which is sometimes a protocol for a lot of surgeries. Like if you are doing a ruptured aneurysm surgery, a good idea is to place a pre-op lumbar drain so that you can draw out the CSF and relax the brain. Another option is to open the basal cisterns. Now, that depends on the surgeon's expertise. That also depends on the pathology for which you are operating, because reaching the basal cisterns in a very tight brain is going to be a very dangerous maneuver in comparison with drawing out the CSF directly. So all these are options. All the options that we use to reduce the ICP and to reduce the brain edema, they are the same options. We need to have a relaxed brain, because a relaxed brain is going to give us the natural corridor. Sylvian fissure is a natural corridor. And that is why it is an excellent route, because in a relaxed brain, the temporal and the frontal lobe are going to be slightly apart, and it will be a lot easier to find the arachnoid planes to move along for the dissection. Let's move on. So I think we are all on the same page here. Fixed retractors are a very bad idea in microneurosurgery overall. The dynamic retraction is always a better option if you're using your non-traumatic retraction or very gentle dissectors to slightly retract instead of putting the fixed retractors in. For the Sylvian fissure, fixed retractors are dually problematic. Why? Let me remind you what was here. We have the frontal lobe here. The Sylvian fissure goes like this. And then we have the temporal lobe here, right? This is how it looks like, sort of. So here, we have the Broca's area, the inferior frontal gyrus, the frontal operculum. We also have slightly posteriorly the motor cortex here, primary motor cortex just behind it. On the parietal side, we have the primary somatosensory cortex. Inferiorly, we have the primary auditory cortex here and the vernix area here. So imagine if you're putting up fixed retractors, the kind of pressure they would put on the brain, which might already be tied, and the small cortical contusions, cortical tears, which might lead to a bigger problem later on in the postoperative period. So, I am not sure what you mean by tell about the types of Sylvian fissure. We have already covered the anatomy of Sylvian fissure. We are not going to discuss it today. We are only going to discuss the Sylvian fissure dissection or Sylvian fissure splitting. So, I think you all get the gist why fixed retractors are not a good idea. What we do is we use a small non-traumatic suction on very low pressure, 5 to 10 mm mercury, and then we use that to gently retract. Then, usually, retracting, if you're working on the dominant side, retracting on the temporal lobe is still going to be safer than retracting on the frontal lobe, because on the dominant side, let's assume we are operating on this portion and we are opening up Sylvian fissure from here, then this portion is relatively less problematic. So if we end up retracting this, it's still going to fare better. Just above this, we have the inferior frontal gyrus, and we cannot put the retractors safely here without compromising the Broca's area on the dominant side. So if you have to have the retraction, temporal lobe is going to be the safer side to retract. But then again, as we discussed, avoid fixed retractors. We move. So understandably, you cannot dissect without a microscope because this is all arachnoidal dissection. The first step is to identify the Sylvian fissure on the brain surface. How do we do that? Obviously, we are going to find this indentation, this groove that looks very visible. And please give me a minute. I am so sorry for the interruption. Let's get back. So we need to identify the Sylvian fissure on the lateral surface. And once we do that, it's a lot easier to proceed. Ideally, if you figure out the superficial Sylvian vein or the superficial middle cerebral vein, please remember they are both the same things. I'll put an arrow. So if you find this out, it will be a lot easier because you can see this huge vessel going around a particular sulcus, and you will know that this is Sylvian fissure. Let me save. As long as the brain is not hugely swollen up, Sylvian is a telltale story. It will tell you where it is itself. But superficial Sylvian vein is the most reliable surface landmark. And we can also see that there will be this arachnoidal thickening around the Sylvian fissure, which is not the case. Okay, I am not sure who this person is. He has circled 4 types surgically, otherwise 5 types. You're right. I'm not sure about your name. You're right about the 4 types, but that is not the course of discussion for this session. Yes, Dr. Fatma, we are not going to discuss it today. We are only going to discuss the Sylvian fissure dissection. We will not discuss the types today. Okay, let's proceed. So, once you see this vessel, obviously it will not be as visible in terms of being a vein or an artery, but we all know that the only superficial vessels around the lateral surface, which are this thick, they are mostly going to be cortical veins. Arteries are going to be the smaller branches of M4 segment, the terminal branches of MCA. So we will identify this vein along the vein, we are going to have these arachnoidal thickenings. Arachnoidal membrane is going to be more layered around it, and you will see this whitish appearance. I'm sorry, I do not have the pictures for them. These are illustrations just to give you an idea. I could not find good surgical pictures. So, what we see here is multiple arachnoidal layers. It's important to know that there is going to be a superficial layer to the arachnoid, and once we split it up, we are going to find these bands. These are also called trabeculations. They connect with the deeper portion of the arachnoid, which is going to be slightly thicker. The superficial arachnoid is a lot thinner in comparison with this deeper arachnoid, which is in the deeper portion of the fissure. It's thicker and it is also continuous with the adventitia of the vessels around it. And once we cross this, God forbid, if we cross this, we have pia underneath. So let's come back here on the first image. This is a coronal section of the Sylvian fissure. What you see here is the circular sulcus of the insula that we thoroughly discussed yesterday. Also, this is the insular portion of the Sylvian cistern. And this here is the opercular portion of the Sylvian cistern, but we all know that, right? In this portion, in the first one, we are going to find M2. So the branches of MCA that you are going to find right along the depths are going to be M2 segment from MCA, whereas in the opercular segment, this is the opercular segment, the one that is I am highlighting now, because it is between two opercula. You see the frontal opercula here, you see the temporal opercula here. In between their lips, there's going to be arachnoid along with these trabeculations. The purpose of these trabeculations is to hold the vessels sort of steadily and provide some structure for them. So, understandably, once we come away from this portion, let me change the color so that it's visible. This was M2 here, and the branches that follow in this opercular portion are going to be M3. We did discuss this yesterday as well. Once these branches leave the opercular portion and they come out on the cortical surface, these are now considered M4. So M4 segment is not going to be a problem while we are splitting it. What we are concerned with is M3, M2, and M1. M2, M1 we are going to come later on. Now you also see this bluish structure here, which is the superficial Sylvian vein. And you see these small, this thinner arachnoid. So the principle is that your first incision is going to be parallel to the vessels. In fact, all the incisions, all the arachnoidal incisions you are going to use are going to be parallel to the vessels. You cannot go perpendicular. If you end up going perpendicular, you will risk the vessel which is lying underneath. So you will have to go perpendicular. And the first incision, I'm going to change the color. Let's see this yellow thing. The first incision is going to be here. Why? Why is that so specific? Because we have two goals. The first goal is to protect the frontal operculum. We discussed that thoroughly. It's an eloquent region. We cannot risk retracting it. The second goal is to prevent this blue structure here, which is the superficial Sylvian vein. So what ends up happening is once we give our first incision here, even if we use the retractor, we are going to take this portion downwards. The vein is secure under its arachnoidal coverings along with the temporal operculum, and the frontal operculum is free, completely free. So always remember that the first incision is going to be parallel to the vessel, parallel to the superficial Sylvian vein, and towards the frontal side of the superficial Sylvian vein. I hope I'm making sense. Let's see it on the lateral surface. You can see that, let me identify, this is the frontal operculum. This is the temporal operculum. And you see that this superficial Sylvian vein is enclosed towards the temporal operculum. Now they have shown here a smaller superficial Sylvian vein here as well. Usually there is this single main trunk that we take along the temporal operculum. The incision goes along this. This is the superficial arachnoidal membrane. It's going to be thin. Once we incise it, the next step is to go through these. The next step is going to go through these trabeculae, making sure under magnification that none of these has any vessels, because a lot of finer caliber vessels will not be visible as reddish or bluish structures. They will be very pale, sometimes off-whitish. So it's really important to use high level of magnification and identify the bands here, making sure that they are avascular. Let's move. So this is just a continuation of the previous illustration, and you can see that the superficial Sylvian vein has been dissected towards the temporal operculum. It's safe under its arachnoidal coverings. The frontal operculum is somewhere here, and you can also see that this illustrator has already dissected some of the bands here, and you can see part of the Sylvian fissure opening. Let's move to the dissection images, and there is nothing new here. We have all discussed this very thoroughly. You can see the pars triangularis. We did spend a significant time on it. You can see the terminal branches of MCA here, the M4 segment, and the superficial Sylvian vein running along. You can also see the arachnoidal thickenings about, but they are a lot more visible in this cadaveric image. On the actual brain, you will see some whitish thickening. I hope you have noticed it during the surgeries. It will not be as dense in comparison. This is a cadaveric image, so obviously a lot of the structures are a lot more visible and membrane-like. So this was the frontal operculum. This was the temporal operculum. So our incision is going to be roughly parallel to this vessel and towards the frontal operculum side so that we can retract it downwards. You can see that in the image C, where the superficial Sylvian vein has been taken along with the temporal operculum and the Sylvian has been opened. Let's move to the next image. We have two techniques. I'm not going to discuss the second technique, but you need to know the name at least. There are two techniques. There's an inside out technique for Sylvian fissure dissection, and there is an outside in technique for the dissection as well. Outside in is the normal workhorse that we usually do in our normal Sylvian fissure surgeries, etc. Inside out is used in specific cases, and inside out is not the most standard technique, and a surgeon who is not familiar with the outside in technique should not attempt this, because this is going to require a much higher level of experience. Outside in technique is what I have demonstrated just now in the previous illustrations. Inside out is when we start around the lemon insula and then we come out, it's also called the paper knife technique. But for the sake of today's discussion, we are going to focus on the outside in because this is the basic maneuver. So we did discuss that the dissection is going to begin around the sphenoid ridge. We have the option of starting at the anterior Sylvian point. The other option is to start slightly posteriorly, right around the Sylvian vein. And we have to take care of all the tributaries and the smaller branches Bipolar is your best friend, but bipolar is also your worst enemy. I think I keep repeating it in different sessions. So bipolar on the lowest possible coagulation, which is workable. Suction on the lowest possible suction, which is workable. If that is okay, then you're going to fare completely okay in case. Let's clear this over. So we open this space between the frontal and the temporal operculum. And the first incision is obviously going to be small. We are going to use the curved micro scissors and run in the parallel space of the vessels. Afterwards, we have these two options. Once the CSF starts coming in and we recognize that we are into the subarachnoid space, we have two options. Either we can use a micro scissor very gently. The safer option is to use a technique which is called hydrodissection. So hydrodissection is nothing but just a fancy name for a cannula, for an irrigating syringe or cannula, whatever you use, and we inject it gently, and we use that to tear the arachnoidal trabeculations away. So this is the gentler method. The other option is to use micro scissors very gently and cotton patties. So we extend the arachnoidal incision parallel to the fissure, parallel to all visible vessels. We avoid perpendicular incisions. And we have discussed this, that arachnoidal bands frequently contain thin venous channels. They might bleed. If they end up bleeding, the best bet is to either use a controlled pressure like cotton patty, etc. If that does not end up working, then use bipolar forceps at the lowest effective coagulation with thorough irrigation so that you do not end up coagulating or doing more damage than you intended to. Once we open the, let me draw here again. Once we open the fissure, let's see, we opened it up. Then what we do is we place cotton patties sequentially. We start placing small cotton patties, which are longitudinal. We gently place them, we do not push them. But once the fissure gives way, because it is a natural corridor, it will start opening progressively. So we can use our patties to progress incrementally and increase our working corridor. You can see that this portion here, this is the dural flap. This is the dural flap. Here is the dural flap as well. And since this portion looks a lot flatter, and this is the site of the sphenoid ridge, this should have been like this. It is not, because extradural dissection has been done and the dura has been flipped over the rondured lesser wing of a sphenoid. So there is space there. And then you see this superficial middle cerebral vein and the frontal and the temporal opercula. This here is the anterior Sylvian point. This is going to give you some natural space. The other option is to give a very small incision somewhere around here so that you can widen it gently. You can see the widened corridor here. Now, remember that since we are working under a microscope, even a few centimeters are going to make a huge difference in terms of the structures that you will identify. Let me make myself clear. If you go in this direction, right along this bony ridge, and you have taken away the anterior clinoidal process, it's a lot more likely that you will encounter ICA first in this portion. Whereas if you dissect this portion here, 1 to 2 centimeters behind, right at the anterior Sylvian point, you open it up, you're going to encounter lemon insula and MCA bifurcation or trifurcation, whatever the anatomy of that particular patient is. So you have to be very sure of what your direction is, how close you are to the anterior Sylvian point, and where you are aiming at. If you go even posterior, let's say that you end up dissecting in this region, then you will encounter M2 and M3 first. You will not see the M1 or the lemon insula. You will see the insular cortex, and on the insular cortex, you are going to see the M2 and the M3 branches. And this region is, it's not going to give you a very straightforward corridor. I hope I'm making some sense, because there are going to be a lot of smaller vessels, a lot of smaller branches of the M2 and M3 segment. Is it clear?
Yes.
Okay. I hope it is. I really hope it is. I would recommend, though, to go and watch a few videos where the actual surgery is happening, so that it ends up making more sense, and you end up building a layered understanding. So, talking of layers, arachnoid in the Sylvian space, we have already discussed, it is also a layered structure. We have the superficial thin layer, then we have the trabeculae, and then we have the deeper layer, which is continuous with adventitia. These two layers you will need to distinguish. These beautiful, beautiful images are from Professor Mustafa Biskaya, and you can see the first incision, which is very small, and then they are progressing the dissection towards a deeper structure. You can see the CSF flowing out. And once the arachnoid has been opened up superficially, you can also see the arachnoidal trabeculations inside this fissure here. So, what do we see when we enter the deep space? This image shows everything that I discussed just now. Let's draw again. If we go right around here, we are going to find the ICA, etc. If we go slightly posterior, we are going to find lemon insula and the MCA. You can see the bifurcation has already happened. And this is the superior division of M2. So lemon insula is going to be somewhere around this portion. It's not visible in this image. Clear all the drawings. But you can see the insular cortex, which is exposed here. And these are the M2 branches, which are then going to make the M3 branches. And this has been completely dissected. So the insular cortex is completely visible. Obviously, it's not going to be as visible in a live patient. Let's move. So once we have reached the deep Sylvian fissure, the deep Sylvian space, one thing that is really, really important to be identified is going to be M1. Why? Because M1 gives these branches that we discussed yesterday, the lenticulostriate arteries. And these lenticulostriate arteries are end arteries. So if we end up compromising these, patient is going to have infarcts in the internal capsule, sometimes basal ganglia as well. So once we cross the lemon insula, once we reach the lemon insula, we should know that after that, there is M1 and there are going to be lenticulostriate arteries. On the cadaveric sections, you see these brightly colored structures, which are thin, fine, very visible. On a living patient, that's not the case. Lenticulostriate arteries are not as easily visible. They are faintly yellowish filaments, and they might often be confused as arachnoidal strands, arachnoidal trabeculations. So if you're not careful with your identification of lemon insula and the M1, then you might end up risking these, and patient might have an internal capsule infarct. Since these are cadaveric and treated images, you see the polymers in the vessels. You can identify all these small perforators which are going around the anterior perforated substance, but they are not going to be as beautifully visible on a normal patient. So the best bet is to identify lemon insula somewhere around here and understand that post M1, in fact pre-M1, it's going to be a very delicate territory, and a bipolar or even a smaller bleeding is not going to be your friend. This image shows one structure that we have not discussed previously. This is Sylvian vallecula. Sylvian vallecula is nothing but this is small tunnel-like space around the temporal lobe, which is part of the Sylvian fissure, sort of. This is where the MCA passes. Right around it, we have lumen here, and you can see the MCA exiting. This is another cadaveric image, and you can see ICA, which is then bifurcating into A1 and M1. And from M1, you see a lot of smaller branches, these lenticulostriate arteries here and here, which are reaching the anterior perforated substance. Once we have completed the deep dissection and whatever our primary surgical objective was, we might use the Sylvian fissure as a corridor for insula. You might use it as a corridor for the basal ganglia, etc. Or sometimes when you are approaching the PCOM aneurysms, etc. There are a lot of indications for Sylvian fissure dissection. Whatever the primary surgical objective was, once we are done, we turn the magnification up and we identify any minor oozing or any minor bleed that we missed, and we tackle it so that we do not end up with an expanding hematoma in the postoperative period. And how do we do that? We ensure everything is clean and clear with warm saline irrigation. Irrigation also is used as a gentle way of coagulation. And oxidized cellulose, thrombin gelatin, we use Surgicel. So they can be used, but since they are foreign objects, they are going to cause this arachnoidal inflammatory reaction. So it's always a good idea to avoid them. Surgicel, like I said, it can cause edema. So just be very careful with the irrigation and everything so that you do not have to use a lot of this stuff. The fissure can be allowed to close naturally. There is no approximation. I think that's pretty understood. So that's a wrap. All feedback and questions are welcome. I'm sorry, I'm very short on time today. If you have any questions, leave them on the WhatsApp group and I'll be sure to get back to them. Thank you so much, everyone. This is a wrap.